Providence University E2C2, and we're working to have the tanning beds and tobacco sales removed from our campus.
Hi, we're the E2C2 team at U of D, and we're taking one step at a time for cancer control.
Hi everyone, we are the McMaster E2C2 team, joining you from Hamilton for World Cancer Day.
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 Good evening, ladies and gentlemen. My name is Ilse Treurnicht, and it is really my great pleasure on behalf of our entire team at Mars to welcome you to this World Cancer Day at Mars, one of 300 World Cancer Day events that are taking place today. And I want to start out by thanking Pat and her team at the Campaign to Control Cancer for bringing us all together here to share some information and learn more about how we can better control cancer. And it's entirely appropriate that the welcoming voices you heard this evening came from some of our young emerging leaders from 5 universities across Ontario that are really building a new coalition of leaders focused on improving cancer control. And some of them will be participating remotely and following us on live stream, but also sharing their ideas and joining the conversation on the Twitter wall. And we have a couple of hashtags for those of you who want to jump in and participate in our crowdsourcing event, WCD Toronto 2013. And there's also a global hashtag, World Cancer Day, and you will have the opportunity to get feedback on both of those hashtags on our stream, so it should be quite fun. Mars is really focused on tackling some of the big, hairy challenges and bringing every tool in our toolbox on the innovation side to those challenges. And on the topic of cancer, it is absolutely clear that it is one of the defining challenges of our time, and we are extraordinarily fortunate in this Greater Toronto area and in the province of Ontario that we have extraordinary expertise in our superb research hospitals, in our cancer control agency, cancer agencies, in the extraordinary clinicians that work on this topic, and many other innovators across the spectrum that are working. But I think this whole project is clearly not going to be solved by any one of us. It needs a new kinds of partnerships, and I think we're extremely lucky that we now have a group of new young leaders who are injecting a whole new set of energies into this process. So thank you to all of them for joining us this evening. I want to also use this opportunity to thank Paul Alofs from Princess Margaret, who I think all of us know is a force to be reckoned with in this, and has been instrumental also in helping us design this evening. And it is now my great pleasure to introduce one of his colleagues and one of Canada's leading experts, Dr. Mary Gospodarowicz. And she has a number of titles that are relevant this evening, so I'll give you the proper version. She's president of the Union for International Cancer Control, and she does all of that right here as medical director of the Princess Margaret Cancer Centre at Toronto's University Health Network, and she's also the regional vice president for Cancer Care Ontario for the Toronto South region. Welcome, Mary.
Thank you very much, and thank you, Pat, and Campaign to Control Cancer for organizing this event. The World Cancer Day is a relatively new day. It has been initiated by UICC and WHO a number of years ago. And this year's theme for the World Cancer Day is how to dispel myths about cancer. And when we think about cancer in Canada, we are very sophisticated. We understand what the disease is. We understand that cancer be prevented and the cancer can be treated and cured. But in many parts of the world, there are many, many misconceptions. And the myths are run deep and broad on all aspects of cancer. UICC is an organization of organizations and brings together right now almost 700 organizations from very small, such as a Coalition of Mothers of Children with Leukemia in Turkey, to very big ones, such as American Society of Clinical Oncology, American Cancer Society, European Society for Medical Oncology, and so on and so on. We are very fortunate to be very actively engaged in the work of UICC, not only in promoting the World Cancer Day, in promoting programs, promoting very active advocacy agenda, and we're supported very much by Canadian Cancer Society, Canada Partnership Against Cancer, Cancer Care Ontario is a very active participant. Cancer is a huge problem in the world, there's not enough attention paid to cancer by most of the governments and healthcare systems. We were very fortunate that last year, United Nations held only the second ever high-level meeting on health-related issues. The first one was several years ago on HIV/AIDS, and last year the second one was on non-communicable diseases. The main focus on non-communicable diseases is cancer, heart disease, and diabetes, the diseases that result in major mortality in the world and that are becoming a growing concern in the world, both in terms of mortality, morbidity, how they affect people's lives, and the economic cost of these diseases. And there is a tremendous opportunity now after the 2011 UN summit to actually put some targets and put cancer prevention and treatment targets into Millennium Development Goals in the next iteration of it. And that's what UICC and other advocacy and NGOs and other agencies are focusing on right now to get traction so that individual governments actually consider cancer care an investment rather than expense. So what are the directions for this year's World Cancer Day? Well, there are 4 myths that we try to dispel. One is that cancer is just a health issue. It is not. It's an economic issue. It affects the whole family. It affects the whole population. And it's also, if you think, as Mary Robinson said, that health should be one of the fundamental human rights, then access to cancer care, prevention, and quality care should be a human right. It certainly is not in many parts of the world. The other myth is that cancer only affects the developed countries, and it's not a problem because in low and middle income countries, it's the infections that cause death and lack of hygiene, lack of water, lack of resources. Certainly the data doesn't support that, and I think there is a looming tsunami of cancer cases coming in low and middle income countries. These countries are totally unprepared to face this. And what we're trying to do is make sure that with the education and knowledge transfer, they can leapfrog and join us in the efforts to prevent cancer and change the course of this disease. The third myth is that cancer is a death sentence. Even in our country, it is believed that there's not much point diagnosing cancer early because if you're going to get cancer, you're going to die. That's very far from the truth. Screening, early detection, early diagnosis, and effective treatment cure over 50% of all cancers, then certainly something can be done. And the fourth myth that we are addressing, cancer is my fate. Cancer is everywhere. It's genetic disease, it's environmental, and I will get it anyway, and there's not much point of changing my behavior because it's going to change my risk. There's plenty of evidence that cancer is preventable. We are very fortunate now that about a quarter of cancers are infection-related, and we have effective vaccines. We know that smoking is responsible for about 30 to 40% of all cancers, and certainly it's been proven over and over and over again that smoking cessation and prevention actually works and decreases the number of cancers and improves survival. And when we think of Toronto, when we think of Canada, our smoking rates are low. They're about 17%, 16%. Seems low, doesn't it? Until you think it's 1 in 6. Every 6th person here smokes. And that sounds totally different. It doesn't sound as reassuring as 17%. So I think there's lots of work to be done. I'm very pleased that we have the opportunity to celebrate World Cancer Day today here, and that we can bring attention to the issues about cancer and improve the engagement. I'm especially pleased to see so many young people in the audience, because we need you to carry the message and to make sure that we can achieve the achievable. We can implement everything we know, and actually the patients can benefit from what we know about cancer prevention, screening, early detection, early treatment, and support. I think in Canada we are very fortunate. We have a healthcare system that's very supportive. We don't have the problems with lack of insurance, lack of funding. There's uniform access. And I think it's very sad to see that not all people in the population take advantage of it. Thank you very much.
November the 2nd. November the 2nd, 2002. November the 2nd, 2002. That was my World Cancer Day. That was the day that my mother, Pat Alofs, passed away from cancer. And that was a day of tremendous grief for my whole family. It changed all my family forever. It changed our neighborhood. It changed the friends of my mom, the kids that she taught at school. It changed everything for us. If you've lost a loved one, someone near to you, to cancer, would you please stand up? Don't just raise your hand. Please stand up if you lost a loved one to cancer. Please stand up. So if you have a look around, you'll see there are very few people that are seated. As a matter of fact, about 40% of Canadians, current trends continue, will be diagnosed with cancer in their lifetime. Please sit down. Thank you. So this is really an epidemic. And World Cancer Day, it's so important to remember and to reflect on where our passion comes from. Our passion to do something, to get involved, whatever it happens to be. Now, World Cancer Day is about coming together globally to understand the importance of coming together to do something important about cancer. But it's also an important day to feel the energy, the passion, and the momentum that we have in this fight. And so we have many students here tonight. You've come out on a cold February night. It's dinner time, right? Okay, this is where I'm going to do a little segue into the energy and the passion that we're going to go through and feel for the rest of this event. So, I worked for a long time in the entertainment industry, in the music industry. I worked for the Walt Disney Company. And I tell you, when I heard the theme about Mythbusters, like I couldn't get the song out of my mind from Ghostbusters. I mean, has anybody had that running through their mind over the weekend or when they heard? Who are you going to call? When there's something strange in the neighborhood, who are you going to call? Ghostbusters, right? Okay, now you're all smiling, you remember that. I'm going to ask you to participate. This could be a first. This is the kind of disruptive thinking that happens here at Mars. I'm going to ask you to join along with me, but I want to change a couple of words. It's something strange. I want to say there's something great in the neighborhood. Who are you going to call? Mythbusters. Okay, will you join in with me and do that? Okay, there's something strange. There's something great in the neighborhood. Who are you going to call? Mythbusters. Okay, let's do it again. There's something great in the neighborhood. Who are you going to call? Mythbusters. Okay, one more time with gusto. There's something great in the neighborhood. Who are you going to call? Mythbusters. All right. For a cold February day, that's well done. Thank you so much. Now see if you can get that out of your mind over the next week as you think about today. So we're here to unite forces. We're here to find energy and momentum, to discover our passion capital, to do something important globally in this fight against cancer. Now today you've heard from Ilsa, who certainly knows so much about innovation and creativity, and you just heard from our wonderful Dr. Mary G, who is, we're so proud of you, Mary, because Mary is the head of the Union for International Cancer Control worldwide. Based in Geneva, the first Canadian and the first woman to be named to the head of the UICC. And Mary, they couldn't have picked a better leader than you to head this up. World Cancer Day 2013 represents a transformational shift in the way we're responding to the global myths and challenges about cancer. No longer are we asking cancer experts to go it alone. No longer are individual countries, developed and developing, working in isolation. No longer are cancer patients, professionals, providers, and grassroots organizations working in silos. No longer are we dependent on the power of knowledge alone to transform our response to cancer. In Canada and across the globe, new leaders are emerging, and broad-based partnerships are tapping into collective knowledge, the intellectual, social, and passion capital needed to realize our common goals. The students, many of them here tonight and watching on the internet, the students who are involved in the Engaging Leaders in Cancer Control project are tapping into their passion capital today and have launched control campaigns at 5 Ontario universities that you heard about. They're watching us on a live stream and participating through Twitter. Have a look at the screens. Just wonderful innovation. They're joined by people watching this presentation on the World Wide Web in India, Winnipeg, London, Ontario, Vancouver, Africa, and Europe. So by tapping into this connectivity of our digital revolution, we can tap into the resources of cancer leaders in developing countries who can help us address the challenge of reaching people in Canada and right here in the GTA, who are seldom screened and sometimes never screened. Through the innovative Canadian Partnership Against Cancer, we're able to share information across our complex system of provincial, federal, and regional cancer services and around the globe, to collect, analyze, and share data and advances more effectively and efficiently. We're building on Canada's global reputation as both a cancer leader and a global peacekeeper, a nation known for our values of diversity, order, respect, and the basic commitment to publicly funded health care for all citizens. We're calling upon and harnessing the passion of everyday people to come together to debunk the myths that are so common about cancer. So I would like to now introduce and welcome to the stage, besides Dr. Mary G, who is here, of course, the Program Medical Director, the President of the International Union Against Cancer, the Program Medical Director of the Princess Margaret, as well as Regional Vice President of Cancer Care Ontario. I'd like to welcome Shelley Jameson from the Canadian Partnership Against Cancer, who joined in 2012 as the Chief Executive Officer. She brings strong executive experience in the public and private sectors, primarily in healthcare, and a demonstrated commitment to the importance of effective partnerships in achieving meaningful outcomes. And welcome to Shelley. Welcome, Shelley. Thanks for coming out tonight. Dr. Craig Earle is a medical oncologist at Sunnybrook's Odette Cancer Center, professor of medicine at the University of Toronto, senior scientist at the Institute for Clinical Evaluative Sciences, and the Director of Health Services Research for Cancer Care Ontario and the Ontario Institute for Cancer Research. Dr. Earle, would you join us, please? Thank you, Dr. Earle, for being here. So we have 3 incredible experts here, and the way that we're going to manage the panel, if it's all right with all of you, is to ask each one of our panelists to address a myth. And we're going to start, and it's about 5 minutes per speaker. There are microphones in front of you, or you have a microphone on. And we're going to start with Dr. Mary Gospodarowicz, who's going to discuss myth 1, which is cancer is just a health issue. Talk about that myth, Dr. Goff-Sports.
Is this on? Cancer is just a health issue. Probably underestimates the impact of cancer on the population at large. You've heard from Paul, when his mom died of cancer, there was an impact not only on the person who died, but on the family, on the community, on people who knew the person. But in addition, cancer has huge impact on just the economy. About half of patients who have cancer develop cancer during their working careers, during working age. There is impact on workplace. And it's not only because the person is ill and cannot work, but because of fear that cancer generates and engenders. There's also a fear of integrating back into the community. So there's an impact not on your family immediate, but also on your workplace. In addition, there's lost productivity. And it's been calculated that if you take the cost of cancer control, and that is prevention, screening, treatment, supportive services, the cost to the global GDP is about 2%. If you take in addition, lost productivity, so people who are removed from the workforce because they're affected by cancer, and their caregivers who may be removed from the workforce because they have to care for their relatives with cancer, the total cost to global GDP is about 4%. So with this myth, I think what we're trying to say is that preventing cancer, treating it effectively, would actually, it's an investment, it's not a cost. Most of the countries' jurisdictions, the system, consider healthcare as pure expense. It's just, don't get sick, it's just a waste of money. But in fact, it's an investment. It's an investment into health of the population. And cancer is one of those conditions where that is really underappreciated. That if you're effective in screening and prevention programs and effective in care, you can actually improve your economic situation. So cancer has a very multidimensional impact on the whole population. It's not only about the person that gets ill.
And now, Shelley, would you talk about myth number 2? Cancer is a disease of the wealthy and elderly and of developed countries. Talk about that myth.
I'm mythbuster number 2. I'm not a researcher or an academic or a clinician, but what I bring to the mission is health system planning experience, and I, like almost all of you in the room, have also been touched by this ugly disease. I guess I'm going to break it down into the various parts of the myth here, and I'm going to start with speaking about the disease of the wealthy. Is cancer a disease of the wealthy? The truth is that cancer does not discriminate. It affects all socioeconomic levels. In fact, in Canada, lung cancer, which is our leading cause of cancer death, is more common among lower socioeconomic status citizens. There also has been an increase in cancer amongst our First Peoples in this country, much more over the past few decades. CPAC works on a system performance initiative and will be releasing a report later this year about socioeconomic status with indicators against cancer. And this type of work supports the work of our partners across the country. On World Cancer Day, I think it's important to recognize that the developing world has different challenges than Canada. There, in the developing world, inequities in terms of access to cancer services can also be associated with socioeconomic status, with lower income populations, as you can imagine, unable to afford expensive cancer medicines and treatments. And other obstacles include the distance to travel to be looked after. So cancer is not a disease of the wealthy, either here or abroad. The second part of the myth is to do with the elderly. In truth, individuals, families, and communities are all affected by cancers at all ages. In fact, as Mary said previously, cancer often most impacts individuals in their prime working years. In Canada, cancer is the leading cause of death for Canadians aged 35 to 64, the leading cause, killing a greater number of younger Canadians than heart disease, injuries, stroke, and diabetes combined. That's an amazing number. In Canada, it is the second leading cause of death for children aged 1 to 14 following accident or unintentional injury. So that's a major indicator. Approximately 2,000 Canadians aged 15 to 29 are diagnosed with cancer each year. And the sad part about this is they often have late detection because they ignore the symptoms and they don't get into the healthcare system early enough. So that's a problem. Also, half of all cancers in developing countries occur in people under the age of 65. So this myth is also busted that cancer is not a disease of the elderly. The third part of the myth is to do with the developed world. Cancer is a disease of the developed world. Well, cancer is really a global issue, there's no doubt about that, and it's becoming an increasing public health problem in lower income countries. Cancer now accounts for more deaths worldwide than HIV, AIDS, tuberculosis, and malaria combined. About 47% of all cancer cases and 55% of cancer deaths occur in less developed regions of the world. By 2030, 60 to 70% of the estimated 21 million new cancer cases are predicted to occur in developing countries. That's the tidal wave, the tsunami that was mentioned. It's in countries that are least able to deal with it. As lower income countries become more westernized, we are seeing a pattern of incidence that's likely to follow ours. So we're going to see more prostate cancer, more breast cancer, more colorectal cancer as a result of that. Over 85% of women who die each year from cervical cancer are from developing countries. That's a shocking statistic. If that's left unchecked, by 2030, cervical cancer will kill as many as 430,000 women annually, mainly in developing countries. So cancer is not a disease of the developed world. I guess in summary, I'd like to say Canada is one of the few countries with a national cancer control strategy, which excites us. And within a global context, we're a leader in providing quality cancer screening and care. At the World Cancer Congress last year in Montreal, where Mary was elected, I learned that 15% of the world's population, including us, uses 85% of the world's morphine supply. That's a stunning statistic. It means the rest of the world is dying in pain. We're very, very lucky to live in Canada. However, there's lots of opportunity in Canada for us to learn from some of the innovations in the developed world, because they're having to get with the program quickly, and they're coming up with ideas that we could transport and use in our vast geographic area. And one example is the use in African countries of telepathology as a way to access new expertise required to deliver cancer care. We could learn from others, and we should be paying attention. So my message is working in collaboration with others is the key to our success to debunk these myths and raise awareness so that we can reduce the burden of cancer on Canadians. Thank you very much.
Thank you, Shelley. The CPAC excellent website has all of the information that you were quoted. There were so many interesting facts there. So thank you for that. Fascinating. And our third panelist, Craig Earle, Director of Health Services Research for Cancer Care Ontario Institute for Cancer Research, will be addressing myth 3. And myth 3 is, simply, cancer is a death sentence. Craig.
There's almost nothing I do in my clinical practice today that's the same as it was when I started in practice 17 years ago. And a lot of what attracted me into oncology was this promise of great research advances and things that change practice all the time. But even I wasn't aware, I think, or couldn't have anticipated how much things have changed because of advances in different ways. So I've been asked to address the myth that cancer is a death sentence. And when I think of where this came from, I think it came from the past, where you only have to go back about 40 years or so, where fewer than 50% of people diagnosed with cancer were surviving it. And today, that number is over 70%. And so why has this happened? I think there are many different things that have contributed to why cancer is no longer a death sentence. We've heard a bit about screening, and we know that for certain cancers, finding them early at a more curable stage can improve the outcomes and increase the chance of cure. But even aside from that, just the greater awareness of cancer. There have been studies that have shown that just being more aware of cancer, and I think a lot of this has to do with getting rid of some of the fear and stigma around cancer, that even people today who are diagnosed with cancer not through a screening program are being diagnosed at earlier stages than they were in the past. So that also is contributing to it. But I think a major thing when we try to pull apart why our outcomes are better is that treatments have gotten better. And so in fact, some of the controversies you may have heard recently about screening and the value of screening have actually come because these contributions of greater awareness, people coming forward earlier, and the subsequent treatments being better have challenged or eroded maybe some of the obvious balance or benefit from screening. So when we think about cancer treatment, traditionally there are three different approaches we take. There's surgery, radiation, and chemotherapy, or what we lovingly call slash, burn, and poison. And so traditional chemotherapy, well, first of all, surgery and radiation are what are responsible for most of the cancer cures. Surgery for most of them, then radiation, and then chemotherapy next. But not a lot has changed in surgery or radiation over the past several decades. Where a lot of the big advances have been with systemic treatment or chemotherapy, which is what I do, which is why I'm right, why I'm saying that. Mary's a radiation oncologist, so we can argue about it. But yeah, it's a good point. So chemotherapy mostly works, traditional chemotherapy mostly works by damaging DNA in cells. And cells that are rapidly dividing, like cancer cells, are more vulnerable to this sort of damage, and that's how chemotherapy works. But the problem is we have lots of other rapidly dividing cells in our bodies, in our hair follicles, in our gut, etc. And so that's why patients getting chemotherapy often lose their hair and have problems with nausea and vomiting, etc. And so a big revolution that's really taken hold in the last decade or so has been the idea of personalized medicine and targeted therapies for cancer. And what I mean by that is that we finally know enough about the biology of cancer that we can actually develop treatments, drugs, and antibodies that can block some of the signals that tell cancer cells to reproduce and grow and form tumors. And so we've been able to develop these targeted treatments that are generally less toxic than traditional chemotherapy, although they can still have important side effects, for sure. And one of the major things about them, though, is that they tend to be more expensive than traditional chemotherapy. So that's a challenge for any healthcare system, ours, the American healthcare system, and in developing countries as well. Just going to take some water here. And so another exciting aspect of this revolution is that we're also often able to pair these treatments with tests, things that we can do on tumor biopsies that can tell us whether a patient is likely to respond or not to a particular treatment. And in that way, we can spare some of the patients from the side effects and the costs that can come with treatments that aren't really going to help them. And so with these advances, we've dramatically improved the outcomes in some diseases that were basically untreatable if you go back a little more than 10 years. Gastrointestinal stromal tumors, melanoma, kidney cancer, etc. Some more common examples are Herceptin in breast cancer or Rituxan in lymphomas. And so lastly, I'd like to touch on another new area that's exciting, which is epigenetics. And what epigenetics is about is things that control whether a gene turns on or off, whether a gene is active. And if you had asked me, or I think most of my colleagues, even just 5 or 10 years ago, what role do things like diet, maintaining a healthy weight, exercise, et cetera, play in the treatment of cancer? We would have said, not much. I mean, maybe there's some evidence that they may decrease your risk of developing certain cancers, but once you have a cancer, it depends on biology or whether it's caught in time or whether the surgeon got it all or things like this. But what we're starting to realize more and more is that things like diet and exercise can actually affect things that determine whether genes, whether good genes or bad genes, actually turn on. Genes that cause cancer, genes that prevent or decrease your risk of developing cancer can be influenced by diet and exercise because they influence levels of things like folate or insulin or other proteins that can determine whether a cell turns on or off. And so the thing that's exciting about this is that it's the sense that we may actually have more control over our eventual fate after having had a diagnosis of cancer than we previously thought. Now, of course, that can be a double-edged sword. You don't want to have a situation where we blame the victim. Your cancer came back because you didn't eat enough broccoli or something like this. I mean, biology still is a major, major feature of this. But I think it's exciting and interesting that there is now starting to be more and more evidence that we actually can have more control, not just about prevention of cancer, but actually how whether it comes back and et cetera. And so I think, just to summarize, that with things like screening, greater awareness and decreased stigma around cancers, smarter treatments that come from scientific discoveries, and maybe the fact that our lifestyle choices can influence these things, we're increasingly busting the myth that cancer is a death sentence. Thank you.
Great.
Thank you very much. That was excellent. And I'd like to begin with you, Dr. Earle, and ask you the first question. Cancer is a death sentence. In the last 10 years of your career, what are the most positive signs in terms of treatment that you've seen, and for what kind of cancers that have increased survivorship?
Over the past 10 years, it seemed like each disease has sort of had its own year. Colorectal cancer was back in 2004, where we had 2 or 3 brand new drugs that worked in completely different ways that we could give to people with cancer that wasn't necessarily curable, but was able to allow patients to live much, much longer than they had in the past. Meaning that in my still relatively short career, treating colorectal cancer has started to feel more like some of the other cancers that have been treatable for a longer time, like breast cancer, et cetera. Kidney cancer had its year, melanomas had its year. It's really incredible the number of new treatments that have come up. Rituxan for lymphoma. So there have been just major advances in many of the cancers that has just improved the lot of patients. As I say, not always are we able to cure, but we're able to improve quality of life, length of life, often with less toxicity than with treatments that we had in the past.
Shelley, question for you. CPAC's really done an amazing job in building out this national strategy. If there was like 1 or 2 sentences that you'd like all Canadians to know and to think about on this day, what would those 1 or 2 sentences be?
So that's a great question. That's not one of my sentences. I would like people to be aware of their surroundings and their responsibility. So there's data, there's evidence now that tells us how we can live our lives in better ways. And I would wish that that information, it's relatively simple, it's things we've known for a long, long time. I wish it was more front and center and people paid more attention. 1, 2, I'd like Canadians to know that we have a national cancer control strategy, that in fact if you live in Lunenburg, Nova Scotia, or if you live in Toronto, or you live up in somewhere in Nunavut, that the benefit of the brains, that I'm sitting between 2 big ones here, the benefit of their work and their understanding is available to all Canadians. And we're almost there, that's the case, even though we're this huge country with not many people. Those are 2 things, I think.
Thank you. Thank you, This one's for you, Dr. Mary. It's a good thing that we have such a superb person heading up the UICC. If the cost to the economy is about 4% of GDP that you described, why do you think that governments and businesses, particularly in developed countries, have not invested more in prevention and in treatment?
I think part of the problem is the myths and misconceptions that still prevail, not only amongst the population, but in the governments. And the overwhelming lack of infrastructure in those countries. However, it's changing now. I mean, I'm on Twitter, if you want to follow me, @MaryKGE, appears there. You can retweet. And it's that way that Agnes Bineswago, who is Rwanda's Minister of Health, tweeted today that 90% of 11-year-old girls in Rwanda have had HPV vaccination. It's a poor country, 90%. They did it. There is data from Uganda and Kenya. They have deployed 100,000 community health workers that go out in the villages and promote cervical cancer screening. And cervical cancer screening, we've known for, I don't know, 40 years or more, that it saves lives. You detect it early, you treat it with surgery, and you live. If you let it go, women in their childbearing age, very young women, die in fairly miserable death. So it's happening, Paul. It's happening gradually. The reason why UICC was so active in the UN summit and formed the NCD Alliance together with heart and diabetes is because nobody listened just to cancer, but if you get together with other diseases, suddenly it becomes a cause. And we think that there needs to be far more investment by the governments in cancer control everywhere. And it starts with knowing what the size of the problem is. It starts with cancer registration. We have very good data on what the profiles of cancers are. But in Canada, I think it's over 95% of all cancers are registered. All the provinces have cancer registries. In states, a bit less. There are some countries, Europe, 100%, some with less. But in Africa, it's less than 4%. Most of the data that you see is extrapolated from small hospital registries. So just to know what the problem is. And the second is invest in prevention. And tobacco is a huge issue. Because in the developed countries, we have rules and regulations. You can't smoke in the hospitals, you can't smoke in shops, you can't smoke in the restaurants, you can't smoke on the planes, you can't smoke in the workplace, et cetera, et cetera. Well, in other countries, you can smoke everywhere, and people do. And if you are working for tobacco industry, and if you can't smoke in Canada, guess where your advertising and where you push to sell cigarettes goes? It's all in low and middle income countries. That's where the sales are. And it's a huge fight because if they would implement what WHO developed, which is Framework Convention for Tobacco Control, which outlined the steps that you should take to prevent addiction to tobacco and tobacco use, then those countries would save themselves a whole lot of problems. Not only in terms of people dying, but in terms of expense of looking after people who get sick. So tobacco control is huge, hugely important. And then investment in the treatment, and that's where the international help matters. We know that just this year, a comprehensive cancer center opened in Rwanda, and the cancer center was an investment and a partnership between a cancer center in the United States. It involved money from the Clinton initiative, from Gates, from other foundations, Common and others put in money, and Rwanda that did not have any cancer center suddenly has a comprehensive cancer center with help where that center then can disseminate the information and create the manpower that could then extend the healthcare to the other parts of the country. You know, we have comprehensive cancer systems in Canada that look after access to care anywhere, but the low and middle income countries have to start somewhere. and they need to develop their own workforce, their own talent, and there's room for partnerships and guidance, and it's happening. I think there are a number of news right now, and especially a lot of tweets are coming out of the World Cancer Day that are quite positive, quite promising.
Craig, I have another question for you. It's kind of a blunt question, but here it goes. If 50% of cancers are preventable, and we've known this for a long time, why don't we prevent more cancers?
Probably because a lot of it isn't easy. So quitting smoking, which is the major thing for people who are addicted to smoking, it's very difficult to do. There's a lot that can be done for that. Obviously, there have been studies showing that nicotine replacement and counseling and things like that. But that's difficult. Once you get past smoking, then often you're into some of these lifestyle things which are difficult. If it wasn't difficult, we'd all be doing it. Eating right, exercising, keeping our weight down. So things are preventable, just like a lot of these things go beyond cancer. Heart disease, diabetes, etc., are influenced by a lot of the same things that influence cancer. And in our, especially in our Western way of life, it's tough.
Shelley, question for you. It seems like the HIV/AIDS folks who are passionate about that cause really did a great job in building awareness and building strategy and building outreach and building a community of supporters. What can CPAC or what Canadians learn from that actually positive work?
Yeah, that's a great question, Paul. And I think I'm a big fan of this book, The Emperor of All Maladies. And if you haven't read it, read it, because it's the history of the cancer movement over hundreds and hundreds of years. And when I first came into this sector, I read it, someone recommended it to me. One of the things it taught me is to make progress, and this is what the HIV/AIDS folks did, it takes the perfect combination of an issue being at the right place, it having a voice that makes sense to people, having the kind of leadership that there have to be leaders around, having a government or governments with the will to invest in these things. And when those things line up, and the science comes along, and when the things line up, you can do great things. But if any one or two of those things are missing, this book actually talks about how long it took for chemotherapy to arrive on the scene and the early days of mistakes and all of those things. So the HIV/AIDS folks brought the issue to the people on the streets, spoke in ways that were understood. One of the key things to me about this forum is I look at the average age in the room. I'm 108. I'm just well preserved. But I look across this room and I think this is great. If we can take the knowledge and experience of sort of the wisdoms of decades of working and impart that knowledge to you. I'm not going to be an effective communicator with 20-year-olds. They don't listen to me. I have a couple in my family, and I can attest to that. But you will. And so if we can actually pass the baton in a way, you already know how to speak to the rest of the people in a way that I don't. So we take your communication skills, and the HIV/AIDS community had that. We give it the facts, the evidence, the science. You have the passion. And we line these things up and go and get the world changed in cancer. I will say one thing. There is one thing I've noticed coming into the cancer control community. There is some envy. There are some people jealous of the attention that cancer gets. And you run into this. There are other disease groups that are unhappy about the attention that cancer gets. And CPAC gets some pressure sometimes to deal with some of these other diseases. My own view is it's the #1 killer in our country. There's lots to be done, and we're trying not to be distracted by that. And those voices will have to come from within their communities as well.
Shelley, thank you very much. Mary, would you like to comment as well on that question?
So I still don't understand. I don't understand why we can still buy cigarettes. Do you? I mean, if somebody invented cigarettes today, it'd probably be classified as class 1 poison, totally outlawed, and you wouldn't be able to produce it. And we need to get angry because it's still, you can still buy it in every shop, in every corner store. There are some quite outrageous things that are happening in other countries where the awareness is less and regulation is less. Children are being offered disguised forms of tobacco to get them addicted. It's totally outrageous. So I don't understand. We had in October, there was European School of Oncology organized a World Oncology Forum when they asked one question. 100 experts, one question: are we winning the war on cancer? And there was one overwhelming sort of impression that everybody in the room was less than passionate, Paul. There was the Richard Horton, who's quite young editor of Lancet, said, why aren't you angry? Why aren't you angry that there is no more investment in cancer, that there's no more progress, that there's no more research, there's no more activism, there's no more advocacy? There are three elements, as Shelley said. Number one, people have to become involved, the younger generation. They have to get angry, they have to get mad, they have to stop seeing their parents get cancer, die of cancer, their friends. The second thing is we have to take advantage of what we know today. If you see somebody who smokes, tell them to stop. If you see somebody in your family who doesn't get screened when they can and it's free and they have access, tell them to go and do it. And the third thing is research. We have tremendous, and I think Elsa probably knows all about it, we have such an underinvestment in research in this country. It's quite sad. We have built huge research engines, and we need to do so much more. Craig was saying today how much progress that has been made. And the progress is being made, and we have huge research engines here in University Avenue. But one area that's underinvested is what Craig does, is health services research. That's the old name. The new name is implementation science. It's actually moved up to a science. And the implementation science is how do you shorten the time from when you know something works to everybody's using that. At the present time in medicine, it still takes far too long from the time we know something works to the time that everybody avails themselves. So cancer is not one disease. It's not simple. HIV/AIDS is actually simple in comparison. There's a virus and there's one disease. But we know what to do. We can build an engine to sort of simplify the situation, but we need everybody's engagement and everybody's help.
Okay, Mary, here's another one for you. Follow up on that. It's another tough question for you. You're the head of the UICC, which is the world's most important cancer control organization. What are you going to do, and how can we help you with this issue of cigarette companies marketing cigarettes in developing countries? What are you going to do about it?
We certainly work, there are huge tobacco control NGOs. We're working with them to stop, to promote cancer control and encourage the governments. But the UICC's main role in the next few years would be to put the cancer on the governmental agendas to get investment, because we know that in tobacco control, the improvements that we've seen from one person telling the other to stop smoking, or even the physician telling the patient to stop smoking, were very, very small. But the public policy change to change regulation on smoking in the workplace and smoking in the airplanes and smoking in the restaurant, and the smoking rates took a dive. I remember where you could smoke in the clinics at Princess Margaret Hospital. The doctors smoked while they were seeing patients. The patients smoked, everybody smoked. We knew that smoking caused cancer. We knew it was bad for you, but it was accepted that some people just smoke. And I remember when the law came in that you cannot. And at the beginning, there were 100 people at coffee break outside smoking, and then there were 50, and there were 20. And today, maybe one person is outside. So it works. The public policy and the public policy implementation works, and what we're going to do in UICC, make sure that that knowledge is transferred to the countries that have no public policy, have none, because that actually works.
Great, thank you. Thanks, Mary.
And how you can help me? Money.
How can we help you?
Money, Paul. Money, Paul. Money works too.
It's always such a pleasure to work with you, Mary. Craig, Question for you on
Yes.
personalized medicine. You talked about the revolution that's happening in personalized cancer medicine. On Sunday in the New York Times, there was an article about a company that was selling a device, a box about as big as a small filing cabinet for $125,000 that a number of leading cancer centers was going to be buying. And it was basically a genomics analytics in a box. It did for about $6,000 a test. It did this limited genome screen and then gave you predisposition and other information based on your genome. So for personalized cancer medicine, the cost of doing that genome analysis is coming down dramatically. But what are we going to do with all that information? What do we need to do as a country to get a strategy together about personalized cancer medicine and this revolution that's happening?
I hosted a Super Bowl party yesterday, and so even though I get the New York Times, I didn't see that article. But
I read it when the lights went out for 34 minutes.
You know, it's an excellent question, because with these great advances come huge challenges. Because if you take any of the diseases that we have, it sounds like what you're talking about also is about predisposition to cancer, et cetera. But even when we're talking about tailoring the treatment of particular cancers based on the genomic profile of the cancer, the types of challenges that bring up include, we used to have, you know, one type of breast cancer, for example. Well, if you start looking very deeply into every individual cancer, there becomes many types of cancer. Some people have talked about each breast cancer becomes an orphan disease, which is a term we use for a very rare cancer. And so if you then need to try to figure out what treatments will work in that particular type of cancer with that particular type of almost unique to the person type of mutation, it becomes very difficult. In general, when we do clinical trials that are trying to determine whether a treatment works, as it is, it takes thousands of patients to be able to figure out whether people are cured or survival is improved, et cetera. And so one of the things that I think this is going to necessitate is greater collaboration, not just across Canada, across North America, but around the world, to try to figure out how to use this type of information. Because if you can segment a particular cancer into many different types, you'll need to do some sort of clinical trial on people with an individual type. And even in a place like Princess Margaret, you may only have a handful of those patients. You'll need to find all of the patients with that particular type of mutation or situation basically around the world to do your randomized trial to figure out whether a drug or a particular treatment works. So with this great knowledge comes new challenges in trying to figure out what to do with it. And maybe I'll just stop there. There's also the issues of how to manage so much information, how to tease apart what's a real signal from noise, et cetera.
Okay, Shelley, I have a question for you. If screening and prevention is such an important part of preventing cancer, are we doing enough? Are we investing enough money in research and in screening and prevention?
So I find, there's a common theme here, and it's about evidence, right? And so I'm quite compelled by how we spend our money right now in terms of has there always been evidence behind the things that we invested in? And the answer is no. Actually, in our health system, that's not the case. Sometimes things are invested in because they're popular or they're hopeful, or there are a lot of other good words, but there isn't necessarily the evidence that they're working. And so as we raise awareness on screening and prevention, we get all kinds of people involved and involved into a system. And I'm starting to understand that for every screen you have a debate about overscreening and about whether or not we're looking too many places for too many things, and we have too many false positives for things. So we have to find that sweet spot in screening and prevention where people on the prevention side, we've raised awareness in a reasonable way, not in a completely fearful way. And on screening, that we're looking at the appropriate times with the appropriate screen for things that might be there, as opposed to looking for everything all the time. And I think I'm quite compelled by some of the stuff I'm reading on prostate cancer, for example, and the PSA test, and how many false positives there are that cause fear and anxiety, maybe cause surgery and treatment that are inappropriate, that leave people worse off than they started on something that they might never have died of. They might die with, but not die of. And so it's hard in Canada to have a discussion about that because our world and our brand is so recognized with our public health system that it becomes really difficult to start talking about those things because people think something's being taken away from them. So I think as we start to put more of this information out and we are driven more by evidence-based policy and funding decisions, we'll make better decisions and they'll be sort of less the flavor of the month.
Okay, thank you, Shelley. Excellent, thank you. Last question is for Dr. Mary G. Mary, we're in Mars, and Mars is about creativity and disruptive thinking, and we have a lot of brilliance around this core. I'm struck by the incredible resource that we have in a lot of our young researchers. I think about Facebook, and I think about Google. These were all, you know, they weren't invented by 50-year-old people, engineers, scientists, 60-year-olds. They're invented by young people. Are young researchers getting enough money? Do we need to get a better way of flowing money to the young researchers who might have the very disruptive, leap forward kind of creativity that cancer research needs?
I think it's very safe to say that there's never enough money for research, but I think if you compare the research funding in Canada, and you're putting us to this test all the time at PMH, you know, what's your productivity? I think per dollar invested in Canada, we probably have better research output than many other parts of the world. I think that in addition to money, what we need to do better is to communicate and collaborate. I know we had a conversation in the back room before we started about Brand having a collaboration and doing consultation about cancer system in Mexico. And we have an initiative at UHN and cancer system in Kuwait, but we don't know that we're working somewhere else in the world and nobody compares the results. I was very aware that Indiana University is building a cancer center in Eldoret, Kenya, while Dana-Farber in Boston was building it in Rwanda. They didn't know about each other doing that. And they could compare the notes and do it better. So, you know, we live in a connected world. We have Facebook, Twitter, we have all that. And we don't use it enough, and people still haven't to figure out not only how to collaborate and communicate, but how to do it effectively. And certainly, being in UICC, one of the biggest issues and challenges that I see is that we don't know what we know. If we could just connect better and harness the knowledge and exchange it better and be more effective and use all the tools that we have today to collaborate, communicate, but use them proactively, maybe we could do more with the resources that we have. One of my colleagues, whom you know, David Jeffrey, always talks, there are two things. There's resources, and then there's resourcefulness. And resourcefulness is how do you do the most that you can with the resources you have instead of just complaining that you don't have enough resources. And I think I see some young heads shaking, saying yes, nodding. So we need to be more resourceful and not just always think that we need more resources.
Great, thank you, Mary. That's a great wrap up. Mary, Shelley, Craig, thank you so much for giving us your thoughts and for busting those three myths. You are Class A myth busters. So on behalf of everybody in the audience, thank you three so much for answering those questions. And now you can join me in welcoming two individuals who are going to address myth number 4. And these two individuals represent such an important part of our whole advocacy and way forward as we look to control cancer. There are two speakers who are both students and are here today, Vivian Lee, and I'm going to introduce Vivian. She's a
a UT grad who's developed a passion for cancer control after a family member's battle. She's now collaborating with other students on the launch of a campaign targeting healthy eating and active living, and plans to advance her career with a MPH. So I'm going to ask Vivian to join us up here. Vivian, please step forward. And joining Vivian is Anita McFarland. And Anita is president of the McMaster Cancer Society. Her career goal is to work in rehabilitation medicine. McMaster E2C2 campaign will focus on advancing informed decision-making about HPV vaccinations amongst students. So Anita, would you step forward? Our two wonderful mythbusters. And would you address myth number 4, the fourth myth that we're going to hear about today, which is cancer is my fate. Okay.
Hi, my name is Vivian, and cancer does not need to be my fate. I've been involved with engaging emerging leaders in cancer control at the University of Toronto, and I want to tell you how I've been empowered through E2C2 to change the cancer game. E2C2 is a student-driven health promotion intervention aimed at creating and advocating for healthy communities in order to control cancer. E2C2 provides students like me opportunities to enact change through policy analysis and creating effective health promotion campaigns. So you've already met some of my E2C2 community action teams across Ontario who created the video that welcomed the panel discussion. And also the students, there's many more students watching on the live stream and participating on Twitter. We're using social media to reach one another and our target audiences in Ontario and around the world. In August of this year, Theo from the University of Toronto team and I attended the World Cancer Congress in Montreal, where we interviewed more than 30 global cancer leaders and helped produce a video about cancer advocacy. We wanted to better understand the role of youth leadership and public participation in reducing cancer risk and transferring knowledge about prevention and risk reduction. So we've heard from these experts here that we know that 50% of cancers are preventable through behavior changes, such as cutting out smoking, reducing binge drinking and use of tanning beds, increasing physical activity, eating healthy, and HPV vaccination. Many of these behaviors are molded and formed during the young adult years, which is why we feel it is key to get this message out to students. Today, we launched 5 different campaigns in universities across Ontario, and they are all addressing different issues, and you can take a look at our website to see what they're focusing on. Some of the things going on at our universities may surprise you. So what does this look like in action? At the University of Toronto, we are using E2C2 as a means to connect and unite the different resources on campus, to work towards a common goal and to create a healthy campus. Our one-step campaign highlights how anyone can just take one step at a time to improve their health and reduce their cancer risk. Additionally, we are planning a healthy campus day during orientation week to engage students and get them excited about creating a healthy campus. And through our campaign, we hope to show U of T's administration that being a healthy campus is important to students. And since it's important to us, it should be important to them too. So cancer has become increasingly prevalent, and I've seen its negative effects on my aunt, my cousin, and my family. But the good news is that cancer does not need to be my fate or your fate. Because of initiatives like E2C2, opportunities to change our world and to become cancer leaders are given to people like me who are not necessarily cancer experts. E2C2 is changing the cancer game.
Good evening. McMaster University has proudly jumped on the E2C2 wagon. Beginning in the summer of 2012, an enthusiastic group of McMaster students came together to control cancer. We connected with the university's administration, and we scanned policies and programs related to E2C2's 5 priority areas. They are healthy eating, physical activity, UV exposure, tobacco, alcohol, drug misuse, and HPV vaccination. The C2CC got started at McMaster when we brought Stephen Lewis here in 2011. He helped us get connected with students who took his Change the World message to heart, and this has really involved our E2C2 McMaster project. Our team has selected the HPV vaccination and smoking cessation as the two focus areas to engage our campus and our student body. Our groundwork has allowed us to create allies within the university administration, including the general manager of McMaster Student Union and the health and wellness manager, just to name a few. Their early support and collaboration has helped us move forward with our campaign. As I speak, the campus action team leaders are hosting an event at McMaster for World Cancer Day. They are connecting with the students, sharing facts, questions, and information on HPV vaccination and tobacco exposure. Today, we are starting a petition for the policy change to have at least one HPV vaccination covered through our university's health insurance plan. We are striving for 1,000 signatures to ensure that we have the student body's voice pushing for this change in our policy. Once completed, we will present the results to the student union, and if necessary, we'll start a referendum. We have collaborated with Leave the Pack Behind, which is from McMaster. It's a student wellness group, and it's a club devoted to supporting individuals in their journey to quit smoking. We are organizing a forum in which students wishing to quit smoking can meet others in similar situations and provide an encouraging environment to continue their smoke-free lifestyle. Our next step is to have nicotine patches available at no cost for the student body. And the launch of our campaign video that you saw earlier has engaged our audience and has been a great stepping stone to control cancer. We have embraced the slogan, "More control, less cancer," throughout our campaign and our campus, and we are very confident to see our plan successfully executed this year. My mantra to life is, even if I knew that tomorrow the world would go to pieces, I would still plant my apple tree. And despite the constant diagnosis, death, and suffering that cancer has plagued us with, I think it is vital for all of us to keep these words in mind as we stand together in confidence to conquer and prevent cancer. Thank you.
Thank you so much, Vivian and Anita. We have microphones, one over here and one more right there. We have the microphone. We also have the Twitter feed coming in. So anybody who's online who would like to ask a question, we can see your question on the big screen, and we'll keep an eye out. And during this part of the session, we're going to open the floor and ask you to ask any question that's on your mind to any of the speakers. And we have such a wonderful range of speakers here today. We have the international head of the UICC, and we have two students who are full of passion capital and doing great work. Really specific action that's very important. So congratulations to both of you. But these are 5 individuals that are uniquely qualified to probably answer your question. So the first question.
It's me?
Yes.
And I am first. I have to apologize. I won't be very articulate, and it's first time I am talking in front of so many people. I am very vocal critic, everything what was said here. Therefore, I'll try to, I know it's a question, therefore I'll try to put a question to everyone, but I will be going by name. Mary. Cancer is a disease. It's an autoimmune system disorder. I have a cancer. That's the reason. 12 years I am studying it, and although I am not a medical doctor, but I am highly knowledgeable. Where you get an idea, the autoimmune disease, what everybody has, what we are sitting here, that it would be somehow a disease. It's an evolutionary process.
Cancer is not the only disease in the world that we know how to treat and to cure without necessarily always having full understanding of what makes cancer progress.
Okay, you are immediately saying however, a disease, you know, and treating, and because you cannot treat it's an evolutionary process, what everybody, for a million years we went through. Everybody what is sitting here has 100 cells, you know, I have to go to the, my apologies to everybody because I am now arguing. I want to place it as a question. Basically, I am coming to the second, I believe the second was Sarah?
Shelley.
Shelley's. I be using a Canadian Cancer Society statistics and American Cancer Society statistics. You were mentioning that it was, oh, I'm sorry. Jane was saying that 50% was in a working age. It is by the Canadian Cancer Society, American Cancer Society, 70% of deaths are over 70 years. 65% of all the cancers are over 70 years. Therefore, it is an old age. When it comes to the younger people, and I can take the leading oncologists in the world, they are saying percentually is forgettable. Therefore, how did you come with the idea that it is a 50% during the working age?
Well, one thing I've learned about all of this is it depends who you're asking, where you're counting, and
I'm
who's
talking
keeping track.
Cancer Society statistic, 2012.
Okay, so I use Statistics Canada 2008 highlights. These are my references, so those are my references. So I...
2012.
Okay, you know what I'm going to suggest? You're obviously very passionate. We love your passion. We have all those speakers are going to be here at a reception after, and you've asked a couple of questions, so I'll ask you to engage the speakers after. Thank you for your passion. Thank you for your questions. Okay, next question. You're asking great questions, so that's what today is all about. So,
thank you so much.
Everybody what is sitting here since you are born, you have approximately 100 cancer, somebody was just mentioning, cells basically decide not to die. Our immune system is able to cover it. But having age, at that time we're using a David Angus.
I appreciate so much your question.
Okay. Thank you so much. Okay. Next question. Thank you.
Thank you so much. So basically, my question today is just regarding, I guess, the stigma surrounding cancer. So less about, I mean, prevention is part of it, but the stigma once you do have it. And I guess recently one of my friends was diagnosed with cancer. And of course, we talked about Facebook and social media and the role that it plays. And, you know, some of the status updates that came about, which is how I learned that she does have cancer, was, you know, gearing up for battle. And, you know, later found out that her cancer indeed was terminal and that she knows this and that her close friends had disclosed this information. And I thought it was quite fascinating, because it was quite different for me, that despite being told her fate, that this is it's at a terminal phase, a young woman, 25 years old, like myself, is saying, you know, gearing up for battle and being that motivation and putting up those, you know, tweets and on Facebook messages. So I guess my question then is, in your opinion, what would be the role of helping to reduce that stigma, and do you think the stigma perhaps is part of the reason why many people avoid the early screening and the early detection, kind of that false pretense that if I don't know, the later I know, the less I have to worry about?
Craig, do you want to take that one?
I mean, I think there's two things that you've raised. First of all, with your friend, there's many different interpretations of how someone can be fighting cancer and what people can be hoping for in such a fight. And so it may be that she completely understands and is aware of the diagnosis and how things will play out, but yet is still hoping for and fighting for maybe a bit longer life, maybe a better quality of life, and things along these lines. So I think it's not necessarily an illustration of stigma related to that, but it could be her interpretation of how she's fighting for hope. Let me think. The second part of your question was about stigma and does that prevent people from coming forward still. You know, I think it is, there are still cancers that we know, especially smoking-related cancers, lifestyle-related cancers, that you know, studies have shown even in the medical community we aren't always as open or sympathetic, I guess, to the situation that has led people to develop the cancers. But again, increasingly, we're recognizing that it's usually more than one thing that's contributed to cancers, that even if it is smoking related, that there are genetic predispositions, that people get these types of cancers even if they've never smoked, that there's a lot of, even just the fact that people grew up and lived in a different time from today when social norms were different, that I think a lot of these stigmas are decreasing, but you're right, they're still there and still exist. So we need to be vigilant to trying to remove any possible stigma that could negatively affect our patients.
Mary, would you like to comment?
You are very right. It's still here with us. I had a colleague, a physician, working in cancer, who developed cancer. Most people around did not expect her to come back to work. They expected her to be cured all right, but they did not expect her to resume her career. These are the people who know, who are in the field, and that's a form of stigma. And many patients will continue to be very optimistic and fight even when they're dying because they don't want their friends to change their attitude to them, to pity them, or to walk away. Terminal cancer can be a very lonely journey. A number of people find that people don't know how to deal with this serious illness, so they just walk away. They go away. So even in our society today, stigma, I think, plays a very important role, and education and dealing with it and support, I think, is very important. So you raise a very important issue.
Okay, thank you. Next question. Thanks for your question. Great question.
Hi, my name is Scott, and this question is for Craig. I just want to hear your thoughts on the recent study from Spain on cannabis' ability to fight cancer, and to talk at the myth of that, I guess, since we're on that topic, about cannabis and its ability to fight and deal with cancer.
So I'll have to admit that I don't think I'm familiar with that study. Cannabis is something that is used to help manage the symptoms related to cancer. We have drug forms of some of the active ingredients that can help with pain, nausea, some of these sorts of symptoms, and it can definitely be effective in that sort of situation. I'm not aware of, is anyone here aware of cannabis as an anti-cancer treatment? In fact,
it's the study released by Spain recently.
Okay.
So.
If it's in the smoked form, there are risks to the lungs that would actually be negative from cannabis. So I can't comment beyond that, unfortunately.
Do you want to give a quick summary of what was in the report? That might help our panel.
Just my research on juicing raw cannabis from people in California that are doctors are using it. I've treated 5,500 people. And Rick Simpson, and using hemp oil in a condensed form. He also has been advocating for the use of cannabis for the treatment and also prevention of cancer. So I was just wondering if the panelists or anyone had any more comments on that, or if they're, the myth of that, because there is a lot. You do see tweets about it coming up here quite a bit on cannabis and its use. So you did talk about chemo, radiation, and surgery. I understand those. I was just wondering if there's anything else.
Mary, medicinal marijuana, what do you think?
I agree with Craig. You know, one thing that happens with cancer is that, and the patients bring it up all the time, if there's something wrong with your car, and you ask your bunch of friends, they say, oh, take it to the shop to fix it, take it to the mechanic. But if you tell your friends, I have cancer, everybody will have an advice what you should do. Everybody becomes an expert. And there's no doubt that as a cancer professional, we don't prefer to know everything, but we try very hard to practice what we practice based on evidence and have a very rigorous approach to evidence. So when patients ask me about cannabis, something like that, I say, I don't know. I don't know of any irrefutable evidence that it's good for you. And sometimes things that on the surface appear harmless because people are using it are not. There was a very famous study in Sweden of beta-carotene. It's just in carrot juice, you know, it's antioxidant, it's good for you. They did a randomized study of cancer patients who were at a very high risk of recurrence. Half of them had beta-carotene, half didn't. Guess what? The group that had beta-carotene had a higher death rate. Nobody would have ever expected it. We actually expected the worst thing would happen and would have no effect. So, you know, I always warn my patients that before you subject your body to something, make sure that there is evidence. And if not, at least make sure that you avail yourself of treatments that have been proven to work. Because we only too often see patients who actually don't follow the advice that's based on evidence and from time to time harm themselves.
Thank you. Can I send you guys a study? Maybe if you guys can look into it.
Sure. Send
Thank
along.
you guys.
Thanks. Thanks for your question. Next question.
Hi, my name's Angela, and first I want to applaud the action of the university students, because it is my true belief, working in natural health prevention field, that it is in our next generation where the answers will come, and it's by changing the lifestyle that starts at the beginning. And so some of those challenges may not be challenges if you start early. My question is to Dr. Earle with regards to, I love the acknowledgement of the epigenetics and its impact, and then now the role of personalized medicine. The question is, what do you see the role of integrative medicine as a way of working towards the true solution, meaning that if now in the past, the cancer treatments, the chemo, are much more of a machine gun effect, and now we're being able to differentiate between good cells and rogue cells. A preventative strategy usually talks about using high levels of plant-based foods and phytonutrients to support the immune system. I'm a certified nutritionist. I know I have some clients where they were formerly in a healthy lifestyle. Once they had the cancer diagnosis and once they chose chemo, and I have nothing against that, it's just that the fear factor sets in, and it's almost, they're afraid that by maintaining some of their healthy eating, they're going to compromise the chemo, because they're saying, well, the chemo needs to kill my bad cells, so I can't take
I know there's a question in here somewhere.
Well,
What's your
the question is whether it's felt, because we have seen those who worked with nutrition and cancer together, their rates of survival have increased, but some still live in the fear, and they may be misunderstanding that now the chemo has more directed effect, and the fear of high levels of antioxidants or high level phytonutrients of negatively negating the impact of chemo may be overstated. That's my question.
Well, I think it all comes down to a matter of degree or amount or level, and I'll go back to what Mary just said about the importance of evidence and having evidence-based practice. Because I think eating what is traditionally considered a healthy diet has good effects. There are concerns when you start taking pharmacological doses of some of the particular elements of what would be in a healthy diet. So a couple of examples. One would be, you had mentioned high-dose antioxidants, and so there is some evidence that taking very high doses of antioxidants, because chemotherapy works by damaging DNA in cells, and antioxidants can prevent damage to DNA in cells, that it can actually compromise some of the treatments that we give, chemotherapy, radiation, et cetera. And so while I don't think anyone would go so far to say, don't eat fruits and vegetables, et cetera, there is a big difference between that and taking supplements that can be, beyond anything that would occur in nature in terms of antioxidants. Folate has been in the news recently because it's another issue that gets into the epigenetic part. We know that people who are deficient in folate can be predisposed to have more cancers. And now we supplement folate in bread, and mostly for neural tube, spina bifida prevention, et cetera. But there's been some concern that maybe cancer rates are starting to rise because of that. And while it's not completely clear yet that that's actually the case, the concern is that while folate can be important in turning off some of the genes that can cause or predisposed to a cancer. We also have genes that work by fixing mistakes in our DNA and protecting our cells, and if those get turned off by too much folate, that maybe you can predispose yourself to cancer there. So it's just to say that because deficiencies in some things can be bad, it doesn't mean that taking super amounts of them are necessarily good, and it's important for us to have, well, the beta-carotene example, that was shown in a couple of studies. So some things that seem like harmless vitamins, if you're taking them in too big a dose, they may actually have negative effects. So it's important for us to be evidence-based. I think normal, healthy diet is one thing, but a lot of supplements we do have to potentially be careful about.
I just wanted to clarify, I didn't mean, excuse me, I do agree with you because that's in terms of isolated nutrients.
I'm going to ask you to speak with...
I just wanted to
you know what?
clarify.
Excuse me. This is not an opportunity to give speeches. Now, I would really appreciate it if you would ask your question after, because we have 5 more people that would like to ask a question. Thank you very much. Thank you. And you know what? Just before we get our next question, Anita, what advice can you give to the student leaders who are here today in terms of getting people to participate in campus, to activate? What advice could you give?
I think that the main thing is trying to get everyone aware on campus. The first thing that we are doing at McMaster is educating our student body. Specifically with our HPV vaccination, we want women and men to know how this can benefit them. And once we have an educated body, especially youth, we're very strong and we have strong voices. And once we are dedicated to something, we will go all the way. Then I feel like things will slowly go into play, which we will be doing specifically with the HPV vaccination. Once we get our petition signed, we're going to go full force with our referendum. So the main thing I think is education. As student leaders, I'm here to hopefully educate people in the crowd on what I know and my leadership qualities, and hopefully they can take that to their school bodies and do the same.
Well, congratulations. Your great clarity and action plan. Great clarity. Go ahead. Next question.
Hi, my name is Jerry. I'm a survivor. And Mary, we met 3 years ago in King City. It was the first conference where they had patients and doctors coming together to talk about 4 different forms of cancer. Why isn't this type of discussion going on between patients and the medical profession? That's question 1. Question 2 is, I'm involved in a support group, and one of our biggest challenges, Dr. Earle, is to get doctors to make patients aware that there are support groups out there that can help people. What can we do to be more effective in getting the doctors, once they diagnose a patient with a form of cancer, to let them know that there are support groups out there to work with them?
Okay, first question, Mary. Why isn't there more dialogue, open dialogue between patients and docs?
Well,
and then Craig will follow up with you on the second one.
As you know, it's increasing. So in our own cancer center at Prince St. Margaret, the support groups are part of the fabric. We have men-to-men and other support groups actually in the building, in the clinics, and refer patients. And our survivorship program, Elixir, works very closely with all the community groups and patient support groups. I suppose part of the issue that we all have, and that's where Paul comes in our foundation, is that any coordination bringing together needs funding. At the present time, as you know, it's not within the hospital's funding, so we look to philanthropy to allow us to have the personnel that would actively seek out this partnership and seek out and promote this collaboration, because we have personally found the patient support groups immensely beneficial for people to understand their cancer journey, what can happen. So I'm with you. I think we need to do more of it.
Shelley, do you want to comment as well?
Yeah, I just thought I'd add patient-centered care is hugely important to the Canadian Partnership Against Cancer. Our board member is made up of both survivors and oncologists and scientists. It's a mixed group. And we have many initiatives where we're trying to embed the patient voice in our advisory groups and in our work. In addition to that, what we're trying to do is I'll say, harvest the best practice for how to keep patients involved in the cancer journey by looking across the country, including PMH and places all across the country, at these initiatives that are the sweet spot, the really good examples. We also fund Cancer Chat Canada, which is we are a funder of Cancer Chat Canada, which is an opportunity for people to find each other online, et cetera. And we're spending some time trying to think about cancerview.ca, a place where people can go and link up with the people they're trying to find. So you're absolutely right. It's really easy for people in any system to forget about who the end user is, and it's fundamentally important to us at CPAC to embed the patient voice in everything we do.
In terms of doctors referring people to support groups, I think most of us view support groups very positively. We're not always aware of where exactly to refer people for particular support groups, and that's where I find places like Wellspring, Canadian Cancer Society, et cetera, are great resources, and often I'll refer people to start there, and they're better able to steer them. Unfortunately, there are some situations where it may be difficult to find a support group. Unfortunately, there are some cancers with very poor prognoses, and it's hard support groups may not exist in the area. Or sometimes patients are in a unique situation, a young person with a cancer that's often in older people. There's the CEO of a group called Young Adult Cancer who talks about support groups. I've seen him give a talk where he says, talking about sex with your parents' friends, because that's what the support group is about, but you're just the wrong age to be there. So there are challenges. It doesn't seem to always be a support group ready, but I think most of us have no qualms about referring people when we can.
We meet at Wellspring in Oakville, and we've been trying for the last 15 years to get urologists and other doctors. We've presented them with a complete package of the pamphlets as well as where we meet. And in the last 15 years, we've had 2 referrals, and we've gone to 8 different doctors. And that's not a unique situation across the country.
Well, you know what? Thanks for your advocacy, because you know what? From my perspective, not being in the medical community, patients need to be way more activists. Patients need to push way harder against the system, because true change comes when the patients push. So thanks for your comments and thanks for your work. Wellspring's a great organization, and thanks for your passion as well. So, Dr. Alex Haddad, you've been waiting for a long time. Your question.
Thank you. And I'm going to refer to something that Mary said that probably most of us missed. You said, let's achieve the achievable. Right? I think that is a terrific goal. Let's achieve the achievable. When you said that, what came to my head was, let's prevent the preventable, let's treat the treatable, and let's make sure we can transcend the inevitable. Yeah? Do we know what is achievable now? Do we have a gold standard? And if we don't, what do you think we could do together to make sure we have it? Because I was looking at cancer statistics, and I think most data we have for the world are at least 5 years old. So how could we bridge the gap between what we should be doing and what is being done now? And again, how could we all contribute to achieving that?
So another saying is, by Voltaire, perfection is the enemy of the good. I say just do it. Do what we know works, and life is not perfect, our information is not perfect, data is not perfect, but I think if we just not forget to do what we know works, whether it's a treatment that's available, whether it's a screening program that's available, just because it's not perfect. I have people saying, well, I'm not going to go to breast cancer screening program because guess what? There's some overdiagnosis. They really don't know what they're doing. But we know it works. It's not perfect, but it works. We constantly, as you know, CPAC, Cancer Care Ontario, everybody constantly reevaluates. As the new knowledge comes in, we perfect our treatments, we perfect our intervention. But my big point is let's capture what's available now while we're trying to improve what we can do tomorrow.
And is there anything we could do to support you during your term at UICC to
Money.
make sure we know? Okay, money. So if you had one wish, it would be more money to get the job done. Okay, thank you.
Money is good. I'd like to, the last 4 people that haven't had a chance to ask a question, I'd like you to hold on to your questions because I see a very special guest in the audience. And I'd like to ask Olivia Chow to step forward. You know, everybody talks about Olivia and says she needs no introduction, but let me just talk a little bit about Olivia. It's so good of you to come out tonight, Olivia, and to say a few words. Olivia worked as a college professor, an ESL teacher, counselor for new immigrants, and a sculptor. First elected to Parliament as an MP for the riding of Trinity Spadina in 2006. Olivia has won re-election twice. Of course, Olivia married Jack Layton, the wonderful Jack, in 1988. And together they forged one of Canada's most remarkable political partnerships, sharing a passion for life and a commitment to change. Since Jack's death in 2011, Olivia has continued the quest to make Toronto a better city, Canada a better country for all. Olivia, would you step forward and say a few words to this group? Olivia Chow.
Good evening, everybody. I just landed to Toronto, so from Ottawa. Just thank you all for being here tonight, for your kind welcome, Paul, and for all the work you do, for the leadership you are showing in a quest that is so dear to our hearts. We can prevent cancer, and we can live with cancer. We can certainly control cancer. Cancer is really not our fate, not my fate, because just because our parents or our loved ones had to die from it doesn't mean that we would. We know this. We know that we can prevent cancer by eating well, living well. We can prevent cancer by telling government to ban cancer-causing substance from our environment. We can live with cancer by better treatment, by establishing government social policies that give flexibility in our workplace so that we can get treatment and also care for each other, and by making cancer drugs affordable. We can control cancer by early screening, by making screening free, by early detection, by research, by knowledge, because we know that knowledge is power. So when I did the recent run for the Run for the Cure, the breast cancer run, and we had that the pink bus. And I spoke to the breast cancer folks, and I said, oh, well, you know, downtown folks, I am sure, because we're so well educated, you know, I'm sure it's the small towns, small communities, remote part of Ontario that have high rate of people not getting the breast cancer screening. And, you know, that's by and large the screening is really successful in Toronto, right? Wrong. Wrong. Totally wrong. I think, how could that be? Apparently, right here in downtown Toronto and in GTA, especially in the immigrant communities, there is very low rate of screening. So some of it is cultural, other is fear, other is lack of information, lack of knowledge. So we need to look at new ways to approach how to deal with cancer, new way to conquer it, new way to get early screening. We know why that's important, early detection, so that we can reduce the fear. I tell you, I have to argue with my mother, because I said, well, have you done the PET smear? You know, what about cervical cancer? You know, breast screening, oh no, don't need it, right? And most of her friends are the same. And it's not just generational. It is, and by and large, it's something that we have to seriously deal with. We have to be creative, and we have to think of new ways. And speaking about new ways, about creativity, we have 2 young leaders, 2 students who are part of our winning campaign to control cancer. Let me tell you something about them. You probably know about them because they've been talking to you. Vivian Lee is the University of Toronto grad who developed a passion for cancer control after a family member's battle. She's now working with other students to launch a campaign promoting healthy eating and active living, and she plans to continue a career focused on healthcare. Hey, I think there probably is some U of T students here, right? I hope to see you at the Athletic Center, at Hart House. I hope we eat well. I hope we can challenge other universities to make sure that we score high on that front. And another student is Anita McFarland, is the president of the McMaster Cancer Society. Her career goal is to work in rehab medicine. The McMaster E2C2 campaign is focusing on advanced informed decision-making about HPV vaccination among students. They are very important initiatives. They will give hope to so many folks. And we do know that treatments and therapies have never been better in the face of cancer, thanks to the foundation. And they've been doing very, very well. So we have every reason to be optimistic, to be determined, and focused on the future. And together, we can prevent cancer, live with cancer, and ultimately control cancer. So thank you for being here, and let me congratulate the two young people that is leading our way. Congratulations to you.
Olivia, thank you so much. We've got a couple of more questions here. But, you know, we talked a lot about genomics and proteomics tonight. If we could clone you, do you think we could get you to be mayor as well?
I haven't thought about that, no.
Okay,
I'm
well,
listening.
you're going to think about that one.
Okay.
So let's, if you would grab a seat, if you would. Yeah, join us. So the last couple of people who haven't had a chance to ask a question, if you could keep your questions short, because we're going to wrap up in just a few minutes. Go ahead.
Hi, my name is Yimin. I'm a first-year master's student in medical illustration, and one of the key things we really focus on is education and effective communication. And Olivia Chow has brought up a really interesting point about how Toronto does not have enough cancer screening. And I can't help but make the connection that, you know, Toronto is comprised of such a large immigrant population, and oftentimes it's usually the youth that are helping the parents navigate the healthcare system. And I'm just wondering, what are we doing other than the fabulous work that university chapters are starting to do? What are we doing to better engage maybe even high school students? And what do you guys think are the challenges that the next generation of youth are going to face, and how do you think we can better equip ourselves for this?
Shelley, you want to take that one? How about the high school students and young people?
Yeah, I mean, absolutely. It's going to take, the influence shifts. And I will say about the younger people that you guys are on the net so much. You have the world at your fingertips, and you are more abreast of things. In some ways, it's easier to get to you. And you're not high school students, but it's easier to get to younger people. We have had some initiatives at CPAC that look at going right into schools, in particular First Nations communities, where we go into schools and start talking really early about healthy living and hoping that they go home and actually change some of the behaviors that are in the household through the knowledge they've gained through the school system. So I think it's fundamentally important, and I think somebody said earlier, we have to keep asking our family members those tough questions. You know, why, Dad, are you not going for your colonoscopy? I mean, really, why aren't you going? It's absolutely the right thing to go when you hit a certain age. You need to go, and yeah, it's embarrassing, and yeah, it's, you know, maybe uncomfortable to get the prep ready, but it's worth it. And, you know, we're not having enough of those conversations. So the best thing the kids can do, armed with the knowledge, is to be asking those questions of the people they love.
That's great. Just a minute when we wrap up, Dr. Brent Schachter is going to come up. And Brent is very well known for a number of things, but he co-chairs a Canadian task force on adolescents and young adults with cancer, and maybe he'll comment on that as well. Look, why don't we have two more questions, because we're running a little bit over time here. Two more quick questions.
Okay, I'll be quick. This isn't for anyone in particular, just whoever wants to take it. I'm curious if there's any initiatives or movements that you know of that are being done around food that's provided in hospitals in terms of the quality of the food. And I was really sparked by it when you were speaking about smoking and how cigarettes, we used to not really know about that, and you could smoke in the hospitals. And now that there's so much knowledge about food and the role that that plays where you see that moving in the future and how that plays into cancer,
Mary?
particularly in hospitals.
Food in hospitals.
Food in the hospital is awful.
Mary, she's never blunt.
One place that walks the walk is Cancer Ontario. I've noticed that when I go there, it's a lot of fruit and vegetables for meetings rather than same with CPAC. So some organizations are getting it. I certainly think that we should be better in the hospitals and schools and everywhere because, and that's what I mean by accelerating change, by learning from other sides. And we know that public policy changes things. So, you know, there's a big escalator up there. Maybe we should just have had stairs and small elevator, because then only the people that would want to wait for elevator would take, the rest of us would take the stairs. So there's changes that we can make to promote healthy living, exercise, and diet by, as you say, what food is available, what you can purchase. If you walk here, Toronto General Hospital, there's like 10 fast food little outlets, although they have sushi, so that's okay. So I think you're absolutely right, and we should be asking for that. And I think rather than waiting till it comes to on the political agenda, if people ask for it, it would happen. There is a video on YouTube, you know, where somebody did an experiment. I think it's from Sweden. They wanted to drive the traffic of people coming out from the subway, not to take escalator, but take the stairs. So they had the video on day one, and everybody would take escalator. And what they did then overnight is they changed the stairs, painting them like the keys of the piano. And if you stepped on that, it created music. And then they showed that within few hours, 70% of the traffic went on the steps. No signs, no nothing, just the fact that it was more fun to walk up the stairs than to take the escalator. And we need initiatives like that to actually force the change rather than just wait for people to change.
Thanks, Mary. Thank you for your question. One more question. And again, all the panelists will be around after to answer your questions. Go ahead.
Thank you. I recently became a volunteer in PMH in the lung clinic. And there was an interesting thing in PMH that there is a huge difference between different clinics. For example, lung clinic and breast clinic, as you can see. And as far as I know, and Mary, you said that lung cancer is the leading cause of death in Canada. And why there is such a difference between the attention that are paid to different kinds of cancers, not only between research centers, even in the community, we can say we have run for the breast cancer or such things, but there isn't any attention to some other kinds of cancer like lung cancer.
I think, Paul, we need to renovate the lung clinic.
Okay.
No, seriously, you're right. It has something to do with movement. I think breast cancer is unique. I think it has something to do with the numbers. It has something to do with women that are very active. But, you know, there's a prostate cancer support group. Prostate cancer has activism. There is Lung Cancer Canada, which is very active in promoting research and support for patients with lung cancer. And I'm not quite sure what you've noticed difference, whether it was just aesthetics or facilities, but we actually think that lung cancer program at PMH is probably more active than any other program in terms of research and innovation and bringing new treatments. So I certainly think that although there are differences, we're trying to move forward on all the cancers, not just breast cancer. The support will vary, but as the time goes on, we know we have a very active myeloma group, a very rare disease. We have a very active group in melanoma that we're supporting. So I think most of the groups, patients groups, demand support, and then we respond. But thank you for volunteering. That would be great to see you at PMH.
Thanks.
So on behalf of all of us, Vivian, Anita, Craig, Shelley, Mary, Olivia, thank you so much for being here and for doing such a great job. Before the holidays, I had a patient say to me something that just was so memorable. And they said they spend their day challenging their fears, not fearing their challenges. And you're fearless in the questions, you're fearless in the answers. Mary, I think Elsa's going to turn off the escalator. And we're going to have brand new food tomorrow at Princess Margaret. Boy, is that a welcome sign. But thank you all so much for coming out. And now I'd like to introduce Dr. Brent Schachter, who's chair of the board of directors, C2CC. And Dr. Schachter is active in practice in medical oncology at Cancer Care Manitoba, where he was formerly president and CEO. He's an active member of the Canadian Partnership Against Cancer. And along with Dr. Ronald Barr, and pertinent to one of the questions that was asked, Brent co-chairs the Canadian Task Force on Adolescents and Young Adults with Cancer. He just recently, in May actually, he's going to be announced, he will receive Distinguished Service Award from Doctors of Manitoba, their highest award. So I'm going to ask Dr. Schachter to come up and close tonight. And before he does, for everyone who's been watching on the internet, who's been tweeting, please keep the tweets rolling. And again, to our panel, thank you so much for doing such an expert job. And Mary, I work with you very closely. From all of us here, you are leading the world's largest and most important cancer organization. And I would like to say from all of us, whatever we can do to help you, we're here to help you. You know, working with Mary, I tell you, I sleep like a baby. I wake up every hour crying.
Well, I guess I can use this. First of all, I'd like to say that I'd also like to reiterate that it is so nice to see so many young people here. You know, the torch has to be passed, and the way I recognize the need to have young people involved in this is really a twofold thing. I have 3 daughters, ranging in age from 35 to 25, and 2 of them are married, and one has a significant other that's 7 years, and it's time they got married. And they're all in their 30s. They're all 30-something. And when they get together with us for dinner or something, I can't understand what they're talking about. And I think, you know, and I'm being really serious about this. I really do think that if we're going to make inroads in the lifestyle changes and lifestyle decisions that young people need to make to be able to prevent cancer from occurring, it has to occur early. And I think the people that are really in tune with what needs to be done and how to do it are people like yourselves. So I'm really pleased about the E2C2 movement and about the involvement of young people and getting more young people and the population at large involved in this. I would like to say, you know, in closing the formal part of this session down, just a few words about the campaign to control cancer. Our mission is more control, less cancer. And the myth-busting approach is to put everything we know and learn to work to cut cancer down to size. Our big idea is to rally a new Canadian response to cancer and to cut cancer rates in half in 1 generation. That's a real stretch goal. But, you know, if you don't try hard, you don't achieve anything. We leverage the collective knowledge and social capital of partnerships with more than 70 cancer patient, provider, and professional organizations across the country. And we're trying to, what is essentially crowdsource the problem of cancer, to mobilize and energize in workplaces, schools, institutions, and in the media, in the digital world and the real world, supporting new leaders and new actions for cancer control. Over the next year, you'll continue to hear from the E2C2 leaders, and you see 2 of them here. That project, by the way, is funded by the Ontario Trillium Foundation. And beginning in April of this year, you'll be hearing about our new National Cancer Screening Awareness Campaign. Canada's Big Screen for Cancer is a pioneering new initiative between C2CC and GE Canada. We're looking for more leaders like GE Canada to join us on screens across the country: cell phones, laptops, smartphones, theaters, billboards, and newspapers. The Big Screen for Cancer will soon be partnering with corporate leaders like GE and busting down myths about screening. Today, we partnered with Mars, Princess Margaret Cancer Foundation, the Ontario Institute for Cancer Research, students at universities across Ontario, and our funding partners at AstraZeneca and Janssen Canada to bust cancer myths and bring the message of World Cancer Day on home. Here to offer his closing remarks is the President and CEO of Janssen Canada, a very generous sponsor of this event today. Please join me in offering our thanks and welcoming Chris Halleck.
Thanks, Brent. I guess, Mary, I'm the one who gave you the money, so you must be happy about that part of it. On behalf of Janssen and the Johnson & Johnson family of companies here in Canada, I want to thank the Campaign to Control Cancer for the opportunity to be able to sponsor this excellent event, and it's a very important event as well. It's an honor to be able to share the stage, if only for a few moments, with some of the leaders in oncology prevention, in research, in innovation, in treatment, and in policy across this country. As an organization, we at Janssen are very proud of the work that we've done in the areas of treatment in cancer, such as prostate cancer with our product Zytiga, in multiple myeloma with Velcade, in breast and ovarian cancer with Calyx, and in the treatment of anemia in patients with cancer with EPREX. Additionally, we as an organization continue to do groundbreaking research in a number of different cancer areas, particularly with exciting new compounds for B-cell malignancies and multiple myeloma that we really are hopeful we'll be able to bring into the marketplace in a very short period of time. Now, as part of the world's largest healthcare company, J&J, Janssen is guided by the Johnson & Johnson Credo, which has been with us for about 75 years. And it provides us with some sound advice on how to make decisions. Our credo actually states that our first responsibility is to patients, to doctors, to nurses, and all of those people who end up using our products. The credo is really our commitment to that around our mission, which is to transform individual lives. In keeping with the theme of today's event, we absolutely do not accept that cancer is a death sentence. We are committed to investing in cancer research aimed at discovering transformational medicines that will offer hope of cure for patients and their loved ones. Today's events highlights, for me, the need for all of us in the healthcare area, the healthcare leaders, the researchers, the governments, the students, who will be the next generation of leaders, the patient groups, and the pharmaceutical industry, that we all have to work together to create a world where preventable cancers are eliminated, where all patients and caregivers have access to cancer treatments and support services that they need, and where the availability of highly effective, targeted medicines will transform cancer into a much more manageable chronic condition where patients can live long and happy and productive lives. So thank you once again for the opportunity for us at Janssen and J&J to partner with the Campaign to Control Cancer in presenting this absolutely outstanding event on World Cancer Day. So thank you very much.
So it finally falls to me to thank everyone, to thank the Mythbusters, and they were just terrific. And we also want to especially thank the innovators and social entrepreneurs at Mars who are helping to bridge the gap between what we know and what we do. Through partnerships, we're accelerating innovation in cancer control by inviting in the crowd, shining a light on knowledge, and dialing up the desire for change. So thank you to Chris and to all of you for joining us this evening. Thank you all very much. And as Paul has mentioned, the panelists will be available if you have some other questions or want to chat with them for till 8 o'clock or so.